Good evening to you all. I hope my voice is audible to you all. Good evening to you all. I hope my voice is audible to you all. So we start the session. Welcome to you all. Good evening. And today's session will be for about 45 minutes. Human anatomy made simple. That has become my sole mission, in fact. It's a war going out there. I used to tell this to my students that going for a PG entrance exam and getting a PG seat is like a war, and you are preparing for that war. And in that war, it is always better to have a guide who has fought this war many times, quite earlier. So you are like students, some of them are very attentive and some of them may be relaxed, as you can watch this guy, but doesn't matter. You have to be trained so that you are working well and not getting hurt too much, but getting the winner flag. So our mission at present is just one, that we have to maximize scoring in our entrance exam so that we are going to get a PG seat, and that PG seat should be in a subject of our own choice, in a college of our own choice. And it is always better that you have a crystal clear vision. Say for example, I want to do obstetrics and gynecology in my hometown, so whichever is the best college nearby, I should get a seat there. Now when it comes to this PG entrance, it is understood that it is focus and defocus kind of story. There used to be these Pandavas trained by Guru Dronacharya, and he is testing them after training, and he's asking them one by one that you have to shoot at the eye of this bird, and before you shoot the arrow I should ask you a question. If you could answer, then only I will let you shoot the eye of the bird. So Nakul, Sahadev, everybody comes, Yudhishthira comes, and Guru Dronacharya is asking them, before you shoot the arrow into the eye of the bird, tell me what do you see exactly. And the Yudhishthira is telling, what I see exactly is what the bird I can see. And what else can you see? The tree, the branches. And what else can you see? The sky, the hut, my brothers. And then one by one they will come, but he will not allow them to shoot. Lastly comes Arjun, and he is asking, Arjun, before you shoot I should ask you a question. And Arjun is aiming. Then when he asks that what do you see, Arjun replies only one thing, that I can see only the eye of the bird. And then he tells, okay, shoot the arrow and it will definitely hit the eye. So the point is focus and defocus. If you're not focused, then your arrow might go here and there. He is not seeing even the bird, let alone the tree or the hut or his brother. So this is the focus which you need, and the approach is very simple. More than 70% of the topics in your PG entrance are repeat topics, and that is why you have to go through previous year questions. अब आप देखेंगे कि 15 साल आखिरी के 15 साल जो हैं, जो लेटेस्ट पैटर्न है उस पर आप गए और आपने कुछ हॉट टॉपिक्स निकाल लिए. इन हॉट टॉपिक्स पर आप काम करते रहें और आप श्योर करते हैं कि आपको 70% से ज़्यादा मार्क्स मिलेंगे. ये एक टेक्निक है जिसे हम काफ़ी लंबे समय से इस्तेमाल कर रहे हैं और हमेशा कामयाब होती है. मुझे कुछ लोग जानते होंगे, काफ़ी लोग नहीं जानते होंगे. मेरा जो एमडी है ऑल इंडिया इंस्टीट्यूट मेडिकल साइंसेज दिल्ली से है, बेंगलोर मेडिकल कॉलेज मेरा पेरेंट कॉलेज है जहाँ पर मैंने MBBS किया, और मुझे 19 साल हो गए हैं पढ़ाते हुए पीजी एंट्रेंस प्रिपरेशन के लिए। और इन पीजी एंट्रेंस एग्ज़ाम को देखते हुए मुझे 22 साल हो गए, क्योंकि मैंने भी तैयारी की थी। तो ये बताने का क्या मतलब है कि 19 साल हो गए या 22 साल हो गए, वो ये कि मैंने कहा एक लड़ाई चल रही है, जंग चल रही है, कमांडर वहाँ पर है, आप सोल्जर हैं, और कमांडर जो कह रहा है सोल्जर अगर फॉलो कर पाएँ तो उनका मिशन ज़रूर कामयाब होगा। चलिए शुरू करते हैं जो आज का असली टॉपिक है, और वो है अपर लिम्ब का डिसेक्शन। उस पर कुछ MCQs आए थे। अब क्या है कि समय हमारे पास सिर्फ 40 मिनट बचा है, तो मैं क्या करूँगा कि अपर लिम्ब एक्चुअली डिसेक्शन 3 सेक्शंस में होता है। सेक्शन 1 को ख़त्म कर पाएंगे और मसल्स के ऊपर ज़्यादा ध्यान देंगे। भले ही साथ में हम नर्व्स, आर्टरी, वेसल्स की भी बात करेंगे, लेकिन शुरुआत करते हैं मसल से ही। तो सबसे पहले हम अपर लिम्ब की मसल्स की बात कर रहे हैं, जैसे मैंने कहा, और यहाँ पर आप देखेंगे कि एक बहुत बड़ी मसल होती है जो कि पेक्टोरल रीजन में है। आपको मालूम है पेक्टोरलिस मेजर। अब ये जो पेक्टोरलिस मेजर मसल है, मैं आपसे जानना चाहूँगा कि इसका ओरिजिन क्या होता है। क्या आप मुझे चैट में बताएंगे कृपया? Okay, some of the students are telling, sir, continue in English. Hindi, keep good. Hindi is better. English, please. So that is an issue, that we have a wide audience, and Hindi सबसे सही है. English is comfortable. English only, English please. So let me make a mixture of the two languages, or I can speak in Hindi and English. No issue. So can you tell me, like, what is the origin of a pectoralis major muscle? It is a wide muscle and it will have a wide origin. So could you write it somewhere, please? Malayalam. Somebody is telling Malayalam. I know Kannada. I don't know Malayalam, but I can speak in Kannada. Sternum, clavicle, right. So it will have a clavicular head, a sternal head, and some of the costal cartilages. It will take the origin. And a question came that this muscle is a spiral muscle. Actually, the fibers will take origin, and insertion will be 180-degree spiral insertion. It will be the lower fibers going upwards. As you will see, these are the lower fibers of the muscle which will insert at a higher level. And where is it inserting? It is inserting to there's a mnemonic, lady between two majors. So it is inserting on the lateral lip of the bicipital groove. So as it goes to the lateral lip of bicipital groove, you will understand the lower fibers are going higher level, and which is the costal, the rib fibers, whereas look at the clavicular fiber. That was the origin. Insertion we want to see, and you will see the upper fibers are coming down. So it is kind of a spiral, that the fibers go 180-degree spiral, and pectoralis major is a spiral muscle. Can you tell me what is the action of this muscle as it is crossing the shoulder joint anteriorly and attaching to the humerus? What will be do? Can you mention in the chat what are the actions of pectoralis major muscle? Yes, flexion, medial rotation, right, correct. Adduction also. So as you can see, it is the origin remains static and insertion will move, so it will take the humerus towards the midline. So A double D, adduction, number one. Number two, it is crossing the fibers are crossing the shoulder joint anteriorly, so it will be causing medial rotation at the shoulder joint. And number three, it can pull the humerus anterior, so it is flexion. So it is flexion and it is medial rotation and it is also A double D adduction. So like that you should remember the actions of the muscles. There is one more muscle which is deep to the pectoralis major, attaching to scapula, under scapula. So it is called subscapularis. Even subscapularis will have the same function, because subscapularis come from the scapula, attaches to the humerus. So it will pull the humerus close, A double D adduction. Because the fibers cross anteriorly, it will rotate the humerus medially. Medial rotation and A double D adduction, they will be the function of subscapularis muscle. The rule is simple. Any muscle which cross the shoulder joint anteriorly will pull the humerus close, A double D adduction, and still close, medial rotation. Now, what is this other muscle which I am marking now? Is called as, what is this muscle? It is also attaching to clavicle anterior surface, but then lateral 1/3. So lateral 1/3 of clavicle anterior surface it is attaching. It also attaches to scapula posteriorly. Actually it will have a J-shaped origin. So that J-shaped origin, scapula and clavicle, this is of course you know deltoid. Deltoid is a multi-pinnate muscle. It will have anterior fibers. So these anterior fibers of deltoid, what they will be doing? If you say anterior fibers of deltoid, they are same like the pectoralis major action, means they can cause medial rotation. So anterior fibers of deltoid, if you are telling insert into the humerus bone, mid shaft of humerus, there is a deltoid tuberosity. This is the deltoid tuberosity. So the anterior fibers can cause medial rotation, but then deltoid is having lateral fibers also. What about the lateral fibers of deltoid? Let us look at that as well now. So I'll be zooming this area, and now you see these are the lateral fibers of deltoid. They attach to scapula, the lateral border of the acromion process of scapula. So lateral border, acromion process of the scapula, these are some lateral fibers. They also insert here into the deltoid tuberosity. Now what do you think they will be doing? Can you write it down in the chat that what are the, or deltoid is a chief muscle of which movement at the shoulder joint? Kindly write it down. Abduction 15 to 90 degrees, somebody has written already. Great. So deltoid lateral fibers, as you can see, origin is the acromion process, insertion is humerus, so it will pull, and as it pulls it will be a muscle of powerful abduction at the shoulder joint. So basically 15 degree to 90 degree. But can you tell me what the posterior fibers will be doing? Now comes the rule. See, it's a very simple rule. Posteriorly it is taking origin from spine of scapula, lower border. So spine of scapula, lower border, that is origin, and insertion is like that. These are posterior fibers, and posterior fibers are antagonistically working as compared with the anterior fibers of deltoid. So what were the anterior fibers doing? Anterior fibers can rotate the humerus medial rotation, but the posterior fibers, they are exactly the opposite. You can see for yourself, these are the posterior fibers, this is the humerus. They will rotate the humerus like this, like this. So it is basically rotating this way, means lateral rotation. So posterior fibers, anterior fibers, they antagonize each other, and then which fibers are left? The middle fibers. And what do? They do powerful abduction. So you have seen the origin, insertion, and the action of the muscle. Where do you give intramuscular injection? Where do you give the intramuscular injection? You have 2 ml of the drug in your syringe, and you want to go 90 degree, of course, but where? You have to understand that there is a nerve which is passing in relation to the surgical neck of the humerus, and as it passes here, the nerve, surgical neck of the humerus, axillary nerve, and along with the axillary nerve you also have the posterior circumflex humeral artery. So as you see, there are 2 things which are at risk of injury under cover of deltoid: posterior circumflex humeral artery, axillary nerve. So you don't want to damage them. Where should you put your injection? Can you write it in the chat? Yes, very good. 2 fingers below acromion. Very good. You people are so smart. The young generation is so smart. You are 10 times better than us. Do you know that? Only thing is, you need a guide. Just guide you and you zoom like anything. I'm so happy, you know. Brilliant. But then you have a lot of energy, it must be directed. Very good, you have answered already. So 2 finger breath down the acromion process, that is very correct. Actually what you can do is, see, I'll just zoom it out because deltoid is not so big in a normal individual. So what you can do is, you can take your fingers like that and put your fingers like that, one which is on the acromion process like that, and then this triangle which you make, acromion process and your fingers on this shoulder area on the deltoid, go to the center of that triangle. And of course, as you told, 2 fingers below the acromion process. So let me draw it here. Say for example, we are putting our fingers like this, 1 here and 2 here. You just go to the midpoint of that. That will be the point where we should give the intramuscular injection. You don't want to damage the nerve or vessel here. And more specifically, it's always better to go posterior superior. It is posterior and superior compartment. That will be better. Somewhere little bit here. But anyway, so that was some applied anatomy here. Let us proceed further now. Now tell me, what is this muscle which is under cover of the pectoralis major muscle? Because these are all MCQs. You know, the way we teach is just to prepare you for the entrance exam. MCQs will come, you have to answer them, and you must be very precisely. There are a lot of things you have to defocus. There is few things you have to focus. I told you, what is Arjuna doing? He is just looking at the eye of the bird, not even the bird. So there are so many muscles here, you don't need to know. You need to know very few, and the one which were asked in the last 15 years. So tell me, what is the origin of this muscle here, which is pectoralis minor? Once you remove the major, you get the minor, pectoralis minor. What is the origin? Tell me in the chat. Yeah, somebody is writing total waste of time. Gentlemen, as you understand total waste of time, these are the questions which are coming in the latest exams next time, mind you. Lot many people don't understand the way I teach, but only when you get a seat you will think back that what Dr. Kaushal was doing there. Anyway, so yes, many of them, they have written 3, 4, 5. So what is the insertion? Let us take this muscle now, and it is inserting into the tip of the coracoid process. Actually not the tip, it is attaching to the superior border of the coracoid process of the scapula. Can you tell me what are the two muscles attaching to the tip of the coracoid process? The muscles which attach to tip of the coracoid process are going towards the humerus. So I will show you one of them here. This is one muscle here which is coming from tip of coracoid process to the humerus bone, and as the name is telling, Coracobrachialis muscle. Can you tell me what is the function of Coracobrachialis muscle? Coracobrachialis muscle, and as you see, it can pull the humerus close, again flexion, but at the shoulder joint. Now there is one muscle which is taking origin from the same place, tip of the coracoid process, but then what is the insertion of that muscle? Let me show you here that this will be short head of biceps brachii. Now short head of biceps brachii, this is the biceps brachii here, and you will find it will have a long head also. So this is the short head of biceps brachii. Where is the long head of biceps brachii taking the origin from? You can see one thing here. This is the long head of biceps brachii. It is running in the bicipital groove along with the one artery branch. So this long head of biceps brachii in the bicipital groove of the humerus run with an artery, and that is called as ascending branch of the anterior circumflex humeral artery. PGI Chandigarh question. Ascending branch of the anterior circumflex humeral artery, and it is following the long head of biceps brachii. This biceps brachii long head is a very peculiar tendon. It becomes intracapsular. There are very few tendons in our body which are intracapsular, and one of them is the long head of biceps brachii. It will go inside the capsule of the shoulder joint. Can you tell me one more muscle which is having intracapsular tendon? Kindly write it down. And yes, you are correct. This tendon is going to attach to the supraglenoid tubercle of the glenoid cavity in scapula. So as it goes to the supraglenoid tubercle above the glenoid cavity of scapula, it will be, that will the origin of long head of biceps. Now this is the long head of biceps brachii, that is short head. Where are they inserted? They have two insertion. Tell me about the two insertion of the biceps brachii muscle here. Now as you come down here, you will see it will having two insertions. One is a aponeurosis, bicipital aponeurosis. So that bicipital aponeurosis is at the roof of the cubital fossa, but the actual tendon, that is the tendon of biceps brachii, and it is attaching to the radius bone. Can you tell me what is the function of the biceps muscle? Write it down in the chat. What is the function of the biceps muscle? Yes, radial tuberosity, correct. So it will be basically, first of all, see, it is coming from the scapula, inserting on the radius. So it will be pulling the radius bone, causing flexion at the elbow joint. Number two, it is a powerful supinator. Take a screwdriver and you want to put a screw. What is the first thing you are doing? Number one, elbow flexion, and number two, it is supination. So it is a powerful supinator. In Erbs palsy, when there is injury of C5-6 root value, there is a partial lesion of musculocutaneous nerve. The musculocutaneous nerve which supplies the biceps brachii is having this root value 5, 6, 7, and it is 5, 6 which has been compromised in Erbs palsy. So what do you think? When the biceps is not working, this reflex will not be working in the Erbs palsy. Which reflex? The biceps reflex. And which movement will be lost? The movement which is lost is, of course, the flexion and supination. That is why, what is policeman tip hand deformity? In policeman tip hand deformity, what happens is this person cannot do elbow flexion, and number one. And number two, there is a difficulty in supination, so hand will remain prone posture, so they come like that. In Erbs palsy, injury of C5-6, you have the loss of flexion and supination, so the policeman tip hand will happen. Can you tell me which muscle is still working in Erbs palsy? Because musculocutaneous supply three muscles here. One is biceps brachii, one is the deep undercover brachialis muscle, and one which you just saw here, it was the Coracobrachialis muscle also. And understand, Coracobrachialis muscle has all the three root value, and because C7 is still working, Coracobrachialis may not be paralyzed. Is a question. Somebody wrote here, I don't know what he is teaching. Let us go to marrow. We'll get some learning in marrow. You know, what is there? You just go there, no problem. See, Dr. Raviraj is teaching very good. Dr. Ashwini is teaching very good. Every teacher has their own way of teaching. Dr. Shrikant is teaching very good. Dr. Ajam is teaching so good. Everybody teaches well. So there is a way of teaching, and some students are comfortable with this group and the other students are comfortable with that group. I don't mind. But the thing is that, are you comfortable with the teaching, and what are the results? Like this teacher is teaching, how many students tell back that whatever he was teaching, the same questions appeared in the exam? And I guarantee you, it is our experience that whatever we are teaching, the same questions come in the exam also. Now it is not a prediction, it is hard work, which I teach you to do yourself. So anyhow, these are the questions which will appear in your exam, and not very far, in December itself, January, the next All India PG. So this is, now can you tell me one thing here? This is the 8th digitation of a muscle, taking origin from upper 8 ribs, anterolateral surface. What is the name of this muscle with the 8 digitations? Coming from anterolateral surface of the upper 8 ribs, forming medial wall of the axilla, going to the scapula bone posteriorly, can pull the scapula anteriorly. And what is the nerve supply? Tell me here. In the chat, you are supposed to tell name of this muscle and the nerve supply. And what if the nerve is damaged? Yes, serratus anterior, very good. And serratus anterior, what is the nerve supply? Yes, yes. Nerve supply? Bell's nerve. You know why it is called Bell's nerve? Long thoracic nerve of Bell. See, first of all, it is a long thoracic nerve of Bell. And when you say that, where is it coming from? It is coming directly from the roots of brachial plexus, C5, 6, 7. Everything is MCQ. Whatever I teach in the class, each line is an MCQ. So it is coming directly from the C5, 6, 7. Now, knife injury in the neck region, this nerve is gone. Or you are operating cancer breast, removing some lymph node, this nerve is gone. It can be damaged in the axilla, it can be damaged in the neck, the muscle paralyzed. This is called long thoracic nerve of Bell, supplying serratus anterior, because when you want to push the doorbell, that time you are doing overhead abduction, and that overhead abduction, to ring the bell, you have to use two muscles. One is serratus anterior, other is trapezius for overhead abduction, 90 degree to 180 degree. Then you have to turn the glenoid cavity superior, and for that purpose you are using this serratus and trapezius. So to ring the bell, you use this muscle. To box, you want to box, you have to use this muscle, boxer's muscle. So long thoracic nerve of Bell. And if it is damaged, what will happen? It is causing protraction of scapula. Pull the scapula forward. You see, this is the medial border of scapula. Pull it forward. push the wall and it will work. So winging of scapula. Do you see winging of scapula in Erbs palsy? Do you see winging of scapula in Erbs palsy? No. Why? Because long thoracic nerve is already given directly from the roots of brachial plexus, and the lesion was in the upper trunk of brachial plexus, which is distal. So nerve is spared. In Erbs palsy, the lesion is distal. It is Erbs point, upper trunk. Nerve is already given. It's working. So there is no winging of scapula in Erbs palsy. Now, let us look at this muscle which is under the scapula, and you can see, since it is under the scapula, we call it as subscapularis muscle, and subscapularis muscle is inserted. See, this is the origin, the costal surface or anterior surface of scapula, but what is the insertion? And insertion of this muscle is humerus, and which area in humerus? It is the glenoid tubercle, it is the lesser tubercle. Now when you say it is inserted on the lesser tubercle, I told you it has the same action as the pectoralis major, because the fibers are crossing anteriorly, it will cause medial rotation and also a double D adduction, and it is one component of the rotator cuff muscle. In the rotator cuff there is one muscle anteriorly and three muscles are posterior superior. Posterior superior, you can call them, they are the sit muscle sitting on the greater tubercle, which is more posterior. So rotator cuff is four muscles, sit, and then there is one more, the S. That was the subscapularis anterior. So subscapularis is anterior. What is the sit muscle which will go posterior superior attaching to the greater tubercle of the humerus? And they will be on the scapula, and on the scapula they are called supraspinatus, infraspinatus, and teres, major or minor? It is teres minor. Now in these four muscles, sits muscle which make the rotator cuff, musculotendinous rotator cuff to stabilize the shoulder joint. Shoulder joints do not get dislocated superiorly or posteriorly. Then where are they dislocated? They are dislocated, write it down, anteriorly, inferiorly. Why the dislocation is anterior inferior? Because anteriorly there is only one muscle, the subscapularis, the forgotten muscle also. A question came. These are AIMS question, PG Chandigarh and All India PG questions. So which is the forgotten muscle in rotator cuff? The musculotendinous support for the shoulder joint capsule. Missing or the forgotten muscle is subscapularis, because people don't write it in the literature. So now anteriorly it is only one muscle, superiorly, posteriorly three muscles. That is why anteriorly there is a weakness. Why inferior? Why it goes inferior? Gravity plus the rotator cuff is deficient inferiorly. So rotator cuff is deficient inferiorly, it will go inferior. The humerus bone is going out of the glenoid cavity, dislocation. Now let us look at the sit muscle as well. But for that purpose, you have to go to the posterior aspect here. Let us look at the posterior aspect of the right scapula, right shoulder joint. So right scapula, right shoulder joint, let us magnify the area. Then we are going to magnify this area now. Can you tell me what is this muscle inserted in a J shape on the scapular bone? It is upper back muscle, and this muscle is taking origin from the occipital bone and also the ligamentum nuchae, the cervical spine, and then it is also taking its origin from the thoracic spines here. Not only it is till the 12 thoracic spine. So 12 thoracic, 7 cervical spine, that is the origin. And I was asking you for insertion. So tell me, what is the insertion? It is not only the spine of scapula posteriorly, but also the clavicle bone anteriorly. In fact, it is actually attaching the same way as the deltoid muscle is taking its origin. Deltoid muscle is J-shape origin, and trapezius has J-shape insertion. What is the origin of deltoid? It is lower border of the spine of scapula and outer border acromion process and anterior surface of the clavicle. So that was the origin of the deltoid muscle, and the same place is trapezius inserted. You can see here now, this is the trapezius, and trapezius is inserted in the same J, inner J, outer J. So what is inner J? Superior border of the spine of scapula and medial border of the acromion process and the posterior surface of the clavicle bone. Now what is it going to do? Trapezius supplied by spinal accessory nerve. What is the function? It's very simple. This is the origin, this is the insertion. Pull the shoulder joint up, and what is it called? It is called shrugging of shoulder. And what if this nerve is injured? There was a lymph node abscess here, posterior triangle of neck, and one over enthusiastic house surgeon, he is not marking surface marking spinal accessory nerve and damage the nerve. Iatrogenic injury. So iatrogenic injury of spinal accessory nerve in the posterior triangle, and which muscle is paralyzed? It has already supplied sternocleidomastoid. Now it was going to supply trapezius. So trapezius paralyzed, drooping of shoulder. So this muscle, if it is not working, there will be drooping of the shoulder. That is the point. But anyhow, we wanted to know about the sit muscle. So let us remove these muscles, the deltoid and also this trapezius, to look deeper to find out that sit muscle sitting on the greater tubercle of bone humerus, making the rotator cuff. Let's do that. So again, we are looking at the right shoulder joint, posterior view, right scapula, posterior view. Let me show you the S muscle. This is the supraspinatus muscle above the spine of scapula, attaching to the greater tubercle superiorly. It is supraspinatus for 0 to 15 degree of abduction, initiation of abduction, supraspinatus. Pull the humerus up, abduction, initiation. Then what is below the spine of scapula? What is below the spine of scapula? The name is telling, infraspinatus muscle. It is also inserted on the greater tubercle. Greater tubercle will have sit muscle sitting. Now if it is the infraspinatus, then what is the T for? And T is coming from the lateral border of the scapula and inserted on the greater tubercle. It is the teres minor. So sit muscle sitting on greater tubercle, making the rotator cuff, stabilizing the shoulder joint posterior superiorly. Posterior superior dislocations of shoulder joint do not happen, they happen anterior inferiorly. Now these sit muscle, as they are sitting on the greater tubercle, what is the nerve supply? And as you will find, there is a nerve which is coming, and it is going to supply scapular muscles. Which nerve is that? That is the suprascapular nerve, and this suprascapular nerve is coming from the upper trunk of brachial plexus. So coming from the upper trunk of the brachial plexus, the supraspinatus muscle supply which muscle? Teres minor. No. Then who is supplying? What is it supplying to? Supraspinatus, infraspinatus. Then who is supplying teres minor? Teres minor supplied by a nerve which is passing quadrangular space and going to surgical neck of humerus, supplying the deltoid also. Tell me in the chat. Tell me in the chat. Who is supplying? Teres minor is not supplied by suprascapular nerve, and it is supplied by, yes, axillary nerve. Very good. So axillary nerve, and which artery was that? Tell me again. Which were passing in the quadrangular space behind the humerus, around the humerus, behind the humerus, around the humerus. Posterior circumflex humeral artery. So posterior circumflex humeral artery, axillary nerve, they pass quadrangular space of the shoulder joint area, go on the surgical neck of humerus. If there is a fracture, surgical neck of the humerus, then you will find, or you are putting a deltoid injection into the nerve only. So you will see deltoid is paralyzed. As deltoid is paralyzed after a few days, you will find difficulty in the abduction. Now tell me, what is the function of teres minor? Crossing the shoulder joint posteriorly. The rule says, if a muscle crosses the shoulder joint posteriorly, it will be working with the posterior fibers of deltoid. So what is posterior fibers of deltoid doing? Write in the chat. What is the posterior fibers of deltoid doing is same being done by the teres minor also. It will rotate the humerus outside. Lateral rotator. Do you know the root value of axillary nerve? Root value of suprascapular nerve? Both of them root value is C5-6. Compromise in Erbs Palsy. So in Erbs Palsy, C5-6 is compromised, suprascapular nerve is compromised, and also axillary nerve is compromised. So these muscles are compromised. Tell me, what is the problem in Erbs Palsy? What is the deformity? Policeman tip hand deformity. What happens? Teres minor not working, so patient cannot do lateral rotation, and deltoid not working, patient cannot do abduction. That is why in policeman tip hand deformity, shoulder cannot be abducted, adducted position, cannot be laterally rotated, medial rotation. So the point is, see, simple. If your basics are good, you are a good doctor. And I want my students to become a good doctor. That is the only purpose. But the problem is, to become a better doctor, you need a PG seat. And for PG seat, I have to teach this way. This is not the way you should teach. You're jumping from one topic to other topic like that and trying to mix up things, and ultimately the students are like, what is this? This is not the way to teach. But I cannot do anything else. I have to jump from topic to topic and mix up things from this end to this end, because examiner also expects that from you. See, we have discussed the muscle, origin, insertion. We have discussed their action, their nerve supply, and their lesion also. This is how you should also proceed. Practice the MCQs as many as possible. And go retrograde. Read from B.D. Charasia. Gray's Anatomy I will not ask you to read from, but read from B.D. Charasia or read from guides. You know, there are so many guides. Even I have written a book, read from that book, and practice as many MCQs as possible, and 70% of your topics are covered. You get 70%. And if you get 70% in all your PG, you are the topper, top 10, top 100. You should try for top 10, you will be in top 100. Try for top 100, you'll be in top 1000. Try for top 1000, you'll be top 10,000. Try for top 10,000, you are nowhere. Always aim high. Always aim high. Your arrow which you shoot will always be pulled down by gravity. So if you aim high, aim for Mars. Maybe then you will reach moon. Elon Musk is already aiming for Mars. Maybe he will land his shuttle on moon at least. So anyhow, very few students would have seen me smiling. That is a big complaint, but I do smile. Only thing is, like I'm a commander in the army, how can I smile? If I smile, then my students will, I don't know what they will do. So I have to be a bit serious, you know, that is the reason. See, this is what some of my students have written. You are a magician. I don't know what I am. I'm just a pure human being trying sincerely to help some of my students, and learning is now enjoyable experience. So if I am able to do a little bit of adding to your comfort, then I'll be very happy. And somehow it is not me only at present, the platform which we are using, the PrepLadder platform. I am very happy to get associated with. Did you see my pony here? See, they have drawn my pony also. My pony they have drawn. And then you see, let us leave this duck somewhere. See, these are the people, my league of extraordinary gentlemen, females included, of course, Madam Swati, and Smiley Madam. Where is Smiley Madam? She's smiling somewhere here. And pediatrics ma'am. So this is a big team, and I'm very happy to also get associated with all this gentleman, Dr. Govind here, Sardarji, our best friend, always telling us not to do this, not to do that, because he's very strict and sincere, means always finding faults with people. But that is good, that will keep us on track. There are some people who will always compliment you, but there are some people who will always guard you so that no damage comes to the person. That is a good tendency actually. And then of course it will not finish off until I tell that there is this gentleman, Dr. Dipanshu, Sahil, Vital, and Sonal, and Mehak, and there are so many. Means it's I told you, the young generation is full of energy, and these people will do miracles. Take it from me. Okay, thank you, thanks a lot. I hope to see you people soon in some good college with a good PG seat. That is my aunt's feeling. That's what I work for. Take it from me. All the best. Take care.